Moments matter. Our hearts are the driver behind these moments, providing life and longevity. Sometimes unexpected things happen, and our hearts need a little extra care and attention. Confidence in your heart care provider is important, and at SGMC, we believe you deserve the best care available in prevention, treatment, and long-term care, at home, and at the hospital. In just a few short years, we've drastically raised the level of our healthcare, investing in cutting-edge cardiac technologies, resources, and building state-of-the-art facilities. And specialists from around the country are taking notice and moving here to be part of it, all coming together to help us continue being the leader in heart and vascular care in South Georgia. Again, memories matter, and we want you to be around to make many more. SGMC Dasher Heart Center, providing care that gets you back to the things you love, faster than ever.
Good evening. It's good to have everybody here tonight. We hope that you've all been able to make your way through the buffet line. If you haven't, please feel free to have some food. I think everything is heart healthy tonight. But that's okay. I'm glad that everybody's here. I'm glad you're able to have this opportunity to hear about some of our wonderful specialists that we have working with us. About a year and a half or so ago, we had a similar event to this where we had some of our physicians and surgeons that are on staff to come by and meet with everybody. And we actually did like a full day of it. This one's going to be a little bit shorter, but I think you're going to be able to get a lot of packed in information today. As many of you probably know, we in the United States, actually in the world, they didn't even do coronary interventions until 1977. And there was a guy that was from Sweden. His name was Grunsvig, as I recall. Maybe one of our cardiologists might remember this. But he came over actually from Switzerland. He's from Zurich, I think. And he came over to the United States. He got a job working at Emory University. And so right here in the state of Georgia is where we had a lot of the very preliminary interventional cardiologists trained right here in the state of Georgia. So it was a really big deal. Unfortunately, he passed away back in, I think it was 1986 in a plane crash. But what he brought to the state was a new recognition of heart disease in a very important way. One of his partners he worked with was a Dr. Hurst, as I recall. I think he was out of Atlanta as well at Emory, and he was well known as kind of the father of modern cardiology. He wrote this special book. It's called Hurst the Heart. Is that it? I remember somebody showing it to me as a neurologist. After seeing the cover of it, I was pretty much done, but that's okay. One thing I can assure you, though, is that the people that we have here, they're going to have some interesting information for you. I'm going to tell you a little bit about our history here in the local area. Back in the mid-1990s, we began to do interventional cardiac procedures here in Valdosta, starting initially with PTCA, which is the abbreviation for percutaneous transluminal coronary angioplasty, which is when they used to put in balloons and blow it up. But we quickly transitioned over to where we started putting in stents. And then in 2001, many of you that may have lived in the community can probably recall whenever we started our first open heart program. And in 2013, we built a dedicated tower, the Dasher Heart Tower, where we have a consolidation of all of our cardiac resources under one roof. And over time, that has slowly built to the point in 2018 where we started our own hospital-based cardiology service, SGMC Cardiology, and a couple of the physicians you're going to talk to today came along with that. In 2014, we started our own cardiovascular group, which was not only heart surgeons, but also a vascular surgeon at the time, Dr. Mari, I'm forgetting Mari's last name now. Mari Solis, who left us to go become dean of the School of Medicine at Mercer University over in Columbus, Georgia. So he left us about 2 years ago, but I'm proud to say that we have a close personal friend of mine by the name of David Hardy, who came in to take his place and has done an outstanding job and has picked up where Dr. Solis left off and went from there. As we've continued to grow over time, we now have cardiac electrophysiology, and I'm going to let Dr. Hanna talk to you a little more about that in just a little bit. We have a structural heart clinic where we do valve work, and we do some very minimally invasive valve replacement procedures that we started in the past year, and we've had outstanding results so far. One thing I want to emphasize to you is, here in the South, we have a lot of heart disease, right? we have a lot of vascular disease in particular. And as a stroke specialist, I can tell you that one thing that I was very attracted to, I completed my training at Mayo Clinic in Jacksonville. But what I knew is that in South Georgia, we had, well, you have what's called the stroke belt, which goes from East Texas all the way across the lower portion of the United States in the southeast. But within the southeast, you also had the buckle of the stroke belt, which starts off in Albany, Georgia, sweeps down the southern end of the state, comes up along the coast and into South Carolina, and about halfway through North Carolina. Well, wherever there's strokes, there's heart disease too. And wherever there's heart disease, there's also vascular disease. It's the same pump and the same pipes that run all over your body, so it's if one part's not working well, the other part's not either. And so I can tell you that as the chief medical officer of the organization, I've taken a personal interest in making sure that we have high-quality physicians that can come in and take care of this problem, because it doesn't matter if the best physician on the planet is sitting somewhere 4 hours away. That's too far away. You have to get in and get treated as quickly as possible. One thing I'm very proud of in this organization is that we've emphasized rapid treatment when it comes to patients who have acute coronary syndromes, and we have balloon times that rival that of any academic center where they have in-house fellows 24/7. The goal is that we should be able to treat people within 90 minutes of them hitting the door, and our average is about 56 minutes, so well beyond the accepted limit. So we're absolutely proud of that. With no further ado, my next guest I'm going to introduce is going to be Dr. Distler. I think we have an introduction video for him.
I'm Dr. Distler. I'm an interventional cardiologist, which means I treat any heart condition from abnormal heart rhythms to blockages around the heart to valvular heart disease. I think it's important that patients understand their risk factors and how those play a role in their cardiac conditions. I'd say if patients are concerned about any symptoms they're having, whether it be shortness of breath or chest pain or anything, that they should talk to their primary care doctor, have them send a referral out to cardiology, and anybody would be happy to see them, including myself. A patient can expect that I spend time with them, that I listen to their story, that I will combine that with up-to-date treatment and guidelines to provide them the best care that I can. A specific patient experience would be when I've been able to walk patients and a specific patient through a tough time medically with their family at their side, and to be able to talk them and their family through their medical problem, to allow them to understand it and to come up with a treatment plan that everybody's on board with. But having the family involved really brings it home for me. I chose to join SGMC to allow myself the capacity to provide excellent care for my patients, to have the support that I need to provide excellent care.
Outstanding. So with no further delay, I'd like to take this opportunity to introduce to you Dr. Distler. He is an interventional cardiologist. He comes to us here more recently. He's just coming directly from Phoenix, Arizona. He grew up in that area. He went to college there in Arizona, and then he ended up going to medical school in West Virginia. He went back and did his residency and his cardiology and his interventional cardiology fellowship all there in Arizona, and now has come back to join the team at South Georgia Medical Center. And then on a personal note, I can tell you that I've been up and around the units, and the nurses up there just absolutely go on and on about how incredibly kind he is and how much time he takes to make sure that he goes in and checks in with each and every patient and make sure that they have the best experience possible. Dr. Distler? Thank you.
So I'm going to have my phone here. I'm on call. If it rings, that's what it's there for. I'm going to talk a little bit off the cuff, but kind of like I do to my patients. My goal with you today is to be the intro into cardiovascular care, to describe what cardiovascular care is, why it's important to you, why it's important to your family, and to kind of have a roundtable discussion about them. I think we can have more question and answers later. I like to describe heart like a house. You got three main components of a house. You have the bones, which is the structure of the house, the doors, the frames. In our heart, that can be the heart valves. And so when we talk about hearts, we could talk about the heart valve. We could talk about the electrical part of the heart. Dr. Hanna is an electrician. He works on the electrical part, and I'll leave that to him. And you could talk about the plumbing of the heart, how it gets the blood supply that it needs to pump. The heart's main purpose is to be the pump that moves the blood around the body, and it needs blood itself via those heart arteries. Myself, Dr. Shoptaw, treat coronary artery disease, which is blockages of those arteries, and we treat them in different ways. Dr. Shoptaw is going to go a little bit more in detail about what that is and why we decide those things, but the fact that we do think about every patient in a very roundabout way, putting our minds together. I want to talk to you about why I am so interested in heart disease. The reason I am is because it's the leading cause of death for men, women, all racial, ethnic groups. The #1 cause of death in America. In the US, one person dies every 34 seconds from cardiovascular disease. That includes heart attacks, strokes. And that's a heart attack every 40 seconds. In 2020, 700,000 people died in the US from heart disease, which is 1 in 5 deaths. And then in 2020 as well, 800,000 people had heart attacks. 600,000 of them, it was their first time, and 200,000 of them, it was their second time. Now, if I boil that down to Georgia, it's 1 in 3 overall. So not just 1 in 5, it's 1 in 3 in Georgia. And that's why I came here. I want to bring that care to you, and we want to bring that care to you. It's important that care is not an hour away, an hour and a half away. I took the liberty, I logged into Lowndes County, the database, to see their health outcomes, and the leading cause of death, 30% is cardiac. The next one down is 13%, which is cancer. So we focus so much on a lot of these cancers and other things, but #1 by twofold is heart. So that's why it's passionate to me and why I am so invigorated to be here to bring that care to Georgia, to small town Georgia. So then what can you do about it? I'll talk with my patients very generically. There's a few basic things. I call them the ABCDs of primary care prevention of cardiovascular disease. The first one is aspirin. Talk to your doctor. Should I take an aspirin? It's a little bit of a debate, but we'll hash that out with you. Should I take a baby aspirin? #2 is your blood pressure control. We got to get your blood pressure down. Whether that means less lemon cake, which is in front of you, and more salad, or medications. We need to get the blood pressure down. So that's A, aspirin, B, blood pressure, C, cholesterol, getting that cholesterol down. And then D is diabetes. We're in an epidemic of diabetes, especially in this area. So it's getting your diabetes under control. And then it's ABCDs, which is the S, smoking. I tell my patients who are smoking, I don't care if you take any of my medicines, throw them in the garbage, but put the cigarette down. That's the #1 thing you can do. And so that's the ABCDs of what you can do to prevent the cardiovascular disease. But what I think is almost just as important to that is the American College of Cardiology came out with, after multiple studies, showing that 30 minutes a day of walking, of increasing your heart rate via walking or riding a bike or rollerblading, however you want to do it, 30 minutes a day, 5 times a week, will significantly decrease your risk of heart attacks and strokes. So that's a big thing about what you can do about it. And then Dr. Dawson talked a little bit about what SGMC can do for you. So you have what you can do, and then what can SGMC do for you? One of the big things I think that I love to focus on with my patients is you know your body. You know when something's not right. When we did the studies on on what heart attacks were, it was in the 80s, and it was on just men. So that crushing under the sternum pain that goes down the arm, that's for men. Women feel different. Women are tougher. Sometimes they just feel like they have reflux when they're having a heart attack. But you know your body and you know what's different. So talk to your doctor when you're feeling something different, when you're feeling something's just not right. So I implore you on that. If I go back to the stats, that's men and women. It's no different. Number one cause of death is cardiac disease. And I want you all with your families. I want you with your babies, your grandbabies. So what can SGMC do for you? Number one, it's being there when something's not right. Call us. Get to your primary. Get to us. Now, when things aren't right, what can we do for you? 24/7, we are on call. We have excellent door-to-balloon times, which means saving your heart muscle when there's a blockage in your heart arteries. That's my job, putting in stents to open up those blockages. We're there for you. We're there right by your side. And we'll get it done quick. Now, what do you do? Hey, it's not an emergency, but I just don't feel right. Talk to your primary care. We'll see you. We'll get you in. What specifically sets SGMC apart? We have multiple, I guess you call them badges or badges of honor as far as cardiovascular care. In 2021, I believe we became the only hospital in the region and among one of only 8 in Georgia that are in the chest pain registry. So that's in 2021, and that's with the American College of Cardiology. So that holds us to a high standard of how we report our data, making sure that we keep excellent care and we are providing that excellent care to the patients. And one of the big things I think is so amazing about SGMC is through their partnerships with Partnerships for Health, through the foundation helping us with providing for indigent care, so that we're not treating just those who have the coverage, we're treating all of those who come to our door. And we all know that some of those without coverage, they don't seek care until it's needed. And we don't care. They come in, we treat them. So I love that. So all that being said, I'm excited, and we are all excited to push kind of cutting edge care to you. And not to be ageist, but I am excited to bring cutting edge care to South Georgia. Every day I'm pushing to bring the things that I've trained on to here, and we are doing that. And so that's my spiel. Thank y'all.
Coming here to Valdosta, to South Georgia Medical Center to establish a new program and give the community what it needs, working with Mr. Ronnie Dean and the leadership of South Georgia Medical Center. They are very excited to establish electrophysiology here for the community and for our patients, and looking forward to work with all the cardiologists and the whole medical community here to move forward and give the community what they need from EP services. People passing out or having rhythm problems, rapid heart rate, slow heart rate, they need to seek cardiology care. Usually they start with general cardiology. The general cardiologist will tell them whether they need to come and see the electrophysiologist or not. I think the general consensus is start with cardiology first, and then you come to EP. Electrophysiology deals with the electrical disturbances of the heart, whether it is low heart rate that leads to pacemaker or fast heart rate that needs ablation therapies, or you can have sometimes cardiomyopathy when the muscles start getting weak and patients end up with defibrillators and cardiac resynchronization therapies, defibrillators. And with arrhythmias, ablations, we have a wide variety of rhythm disturbances of the heart. The most common of which is atrial fibrillation, and that's what I'm looking forward to establish here for this community. We do nowadays state-of-the-art technology, what we call cryoablation. Done over 500 cases with cryoablations and very good results. Really, it's a wide spectrum of specialty. It encompasses, as I always say, electrophysiology encompasses cardiology, interventional cardiology, surgery, and electrophysiology in one specialty.
Outstanding. So before I came this afternoon, I went ahead and shot out a text to everybody that's going to be speaking before you tonight, just to, hey, send me, where are you from? Where'd you go to medical school? Where'd you go to college? Where'd you do your residency? Where'd you do your fellowship? Where'd you do your second fellowship? I got this. I sent it to Dr. Hanna. Where are you from? Georgia. Not applicable, to be determined, to be determined, to be determined. Frisbee, and I can catch a grape in my mouth. U.S. Navy. So I have a daughter named Hanna. That's what happens when you write text and you don't have your glasses on when you're typing it to somebody. So, I'm at that age, I need to start using these glasses a little more liberally than I was before. So, if you ever wonder about my child, she has a lot of skills. She can catch grapes in her mouth. I don't know if Dr. Hanna has that capability or not. But one thing I did learn about him was that he went to the American University of Beirut, which is a very highly regarded medical school in and of itself, but more importantly, is he actually did some of his training at the Karolinska Institute in Stockholm, Sweden. I went there back in 2017 and had an opportunity to tour that actual facility, and it is one of the absolute finest institutions on the planet, to be honest with you. Thereafter, he came here to the United States. He went to Mercer University to do his residency. He trained there. When he was there with Dr. Joe Johnson and Dr. Randy Brown, for those of you who know those guys. He also went out to Arkansas, where he did his cardiology fellowship in general cardiology, and he did his cardiac electrophysiology. Dr. Hanna came to see us back in, I guess it was a little before 2022 when he first came to visit with us, but then he came back and he signed on to move his practice down here. He'd been over in Albany for about 15 years and very, very highly respected there. Dr. Steve Kitchens, who I know Dr. Hanna knows, who's the chief medical officer there, he and I are personal friends. And Steve, if anything, he's a nice guy, but he's also very honest. So I called him up and I said, I want to ask you about somebody. I want to ask you about Dr. Kamil Hanna. He said, I've heard that he might be leaving, and he said, I would trust him with myself or anybody in my family, hands down, without a question. And if we can't keep him, I hope to God that he'll come to you because we need him in the region. And the nice thing is a lot of his patients followed right down here, and they come to see him here as well, and we're proud to have him. Dr. Hanna, you want to come up and tell us a little bit about cardiac electrophysiology, sir? Thank you.
Appreciate these kind words of introduction. It's very humbling. Thank you, Stephen. Well, I was asked to make a little short presentation to you about what is electrophysiology. As the video shows, we talk about rhythm management, whether it is low heart rate or fast heart rate or cardiomyopathies. And when I was asked to make the speech, I understand we got about 15 minutes, so I tried to sit yesterday evening and say, what are we going to show the audience? And I came up with 10 slides, very simple, 10 straightforward slides. Let's see if I can run it up. Okay, pacemakers, patients with low heart rates. There are certain strict criteria for who gets pacemakers. Symptoms is the driver. If you got symptoms, dizziness, lightheadedness, syncope, near syncope, you gotta get a pacemaker, provided if you have low heart rates or AV block. So the first pacemaker, Ellen Bucken, is the electrical engineer. After World War II came, he was working in a garage in Minneapolis. And they were doing some shop works. And then his wife, I believe, was an ICU nurse, was working at the University of Minnesota. She was working with a cardiothoracic surgeon in 1957. All pacemakers were about big, bulky boxes. They would hook up to a patient, and the patient basically committed to bed until that condition resolves or patient dies. The surgeon tells Mr. Bucken, he said, I wish you can make me a pacemaker that I can implant. Within 3 weeks, that was done. They created first pacemaker. Of course, it was bigger than this. It was bigger and bulkier. Used to be implanted in the abdomen. The first pacemaker implant in 1957 in the United States, worldwide actually, the first time. And over the years, many other versions of this pacemaker. Now it is the extent of about a little bit larger than the quarter. And different manufacturers we have. In this slide, you see Medtronic, which is the first manufacturer of pacemakers in the worldwide. And there's other manufacturers, not to show bias to anything. Boston Scientific is an American-made company. St. Jude is an American-made company. There's also Biotronic in Germany. They make good pacemakers. Lately, the most recent version is this little device at the bottom. It's called the Micra. It's literally as big as a vitamin pill. And of course, there is also indications for who gets it. This device is implanted from the groin, unlike the traditional pacemakers, which are now implanted under the clavicle. The Micra is implanted from the groin, and the whole device is what we call the leadless pacemaker. And it sits in the upper pacemaker generally delivers up to 12 and 15 years battery longevity. The micro pacemaker delivers between 8 and 9 years. A little bit less, but you can imagine the difference in the devices. Next, defibrillators. A little bit larger than a pacemaker, but it does a different job. At the base, a defibrillator is also a pacemaker. It can prevent patients from having low heart rates. If your patient is having low heart rate pacemaker, part of the defibrillator will pace. But most importantly, we implant defibrillators for patients that are at risk of sudden death, be it cardiomyopathies, being congenital QT syndromes, be it hypertrophic cardiomyopathy, or patients who have survived a previous events of a cardiac arrest. These devices are implanted traditionally through the left subclavicular area or right subclavicular area here through leads implanted inside the heart, as the form shows here. Most commonly, Medicare insurance company wants us to implant single leads because they're a little bit cheaper. Personally, after 23 years of experience, I like to implant 2 leads because it gives the computer chip of the device a little bit more sense, more technology. It tells the defibrillator when to shock appropriately. And actually, there was a study published about 20 years ago showed that if you put 1 lead versus 2 leads, the 2 leads have the upper hand of avoiding inappropriate shocks. Just for the medical personnel in the audience. So traditionally, over the years, I've always been leaning towards put 2 leads in these patients. Next, and along the, let me see here, what's here? This is pacemakers here. Let's go to the next one. Okay. Not everybody can receive regular defibrillators. And for example, patients on dialysis, they have had subclavian accesses, shunts implanted, AV fistulas implanted, but they still need a defibrillator. They still have cardiomyopathy or have suffered a cardiac arrest and they survived it. In 2013 or 2014, one of the American manufacturers, Boston Scientific, came up with the subcutaneous ICD, as you can see it. These are devices that are implanted in the axillary area. There's no leads implanted inside the heart whatsoever. The leads is tunneled in the subcutaneous tissue and the peristernal area to implant the device here. And actually, these are the devices as recommended by ICC for people who have dialysis or have had a prior history of infections, because the device, this whole system is put under the skin. And it still does the job of delivering shocks if the patient is at risk of sudden death. I'm looking at the watch here. This clock here. It's general surgery. You have to put the device in that order, and it does the job, actually. It has the capacity to pace to an extent, but mainly it shocks the patient if he goes into cardiac arrest. And this is exactly how we do it. It's put in the axillary, so you feel like somebody has a wallet on their side, but it's implanted under the skin. The beauty about it, if the patient gets an infection of the heart or any kind of infection, that infection is not going to be spreading to the device. And if the device gets infected, the patient is not going to get an infection of the heart, unlike the traditional pacemaker and traditional leads. We've done a couple of cases, actually, of the subcutaneous ICD here at South Georgia Medical Center. Next subject I'd like to talk about is my passion is really atrial fibrillation. Edward Naturelli is a prominent electrophysiologist in the United States, published data in 2009, said that we have about 5.1 million Americans with AFib. Well, the last number I heard about a couple of months ago, we have 11 million in the United States with AFib right now. And traditionally, I remember when I did my EP fellowship at the University of Oklahoma, we used to start cases around 7:30 in the morning and finish at midnight. We're talking about 17-hour cases. I used to tell, you've heard me say this before, my mentor and my program director at University of Oklahoma, Sonny Jackman, one of the leads authority in electrophysiology in the world. I used to joke with him, Sonny, how many orders of pizza are we going to have today? Start at 7, 6 o'clock, pizza comes in, Pizza Hut. At midnight, we're ordering Papa John's because we're still working on the same patient. In 2013, cryo came in. One of the American manufacturers, Medtronic, also jumped on it. It used to be called Arctic Front, which is developed by a smart lady engineer from Canada. And she approached a couple of electrophysiologists in Italy and France, and they did some handful of clinical trials. And they said that cryo does the job. We're trying to get rid of the trigger points in the pulmonary veins. And the Mayo Clinic did a study called the Stop AFib in the United States, and it was published in Circulation in 2013, and very shortly afterwards, it gained approval by the FDA to proceed and start doing cryoablations. What do we do with cryoablations? We're trying to get rid of the trigger points involved in the pulmonary veins. So the management of AFib goes from medications to pacemakers to eventually ablations. The ablation technology is this. This shows you on the left side what we used to do in Oklahoma when I used to burn inside the veins, and as I said, after 17 hours, that vein is still firing. Cryo does better. Yesterday, I was showing Dr. Distler a case we did yesterday morning. I stuck the patient literally around 8:30. By 11 o'clock, I walked out. We did fib and flutter ablation on the same patient. And here's how it looks, actually. There it is. This is a patient. This is an actual patient. Was done here yesterday morning at South Georgia Medical Center. Here's the left atrium. We got 2 veins connecting the left lungs and 2 veins from the right. This is like almost 2 Mickey Mouse ears from the left and 2 from the right. Purple color is healthy. The red and orange in the upper lower left is very angry trigger points within the veins of this patient. This is the picture we showed yesterday to Dr. Distler himself, and I was showing this is what we did. This is before ablation, and this is how it looks after ablation. Basically, isolated all the veins connecting all these trigger points, and that patient is in sinus rhythm. We finished, then we went to the right side of the heart. We did a flutter ablation. On flutter, we still use the radiofrequency heat catheters. We are showing these red dots connecting the tricuspid annulus all the way to the IVC, and you drew flutter lines. We were done with the whole case in about 2.5 hours, and patient went home this morning around 10 o'clock. Compared to where we were 23 years ago to where we are today, I was joking yesterday with my staff, I wonder where we're going to be in about 20 or 30 years down the road. The way the technology is evolving, the way electrophysiology joins parallel to computers, because it's all electricity. Last, I'm going to talk about, let's see here, this is a Watchman. This is where we're heading into. For the last 5 years, the FDA has approved the Watchman. Now, what is the Watchman? It's a plug-in device we implant in the left atrium. AFib, is, as Dr. Distler alluded, is a major factor triggering and causing strokes in the United States. Standard of care for those people who qualify or who are deemed at risk of stroke, we put them on blood thinners. Whether it is Coumadin in the old days, now it's Eliquis or Xarelto or Savaysa or Pradaxa, we got options to choose from. Blood thinners do have risk of bleeding, of course, and not everybody can either afford them or who have used them have had bleeding complications with it. And certain risk factors, if you have diabetes, hypertension, or have had a previous stroke, you should be evaluated for the Watchman. And what is the Watchman? It's a small little metallic covered with a mesh material that we put inside the left atrial appendage. And originally, when the protocol was made, we used to have patients on blood thinners for about 6 weeks. After 6 weeks, we're obligated to go back and do what we call transesophageal echo to make sure that that device has sealed and there's no leakage around it. And after that, we stop the blood thinners, we go to aspirin and Plavix for about 3 months, and then we stop Plavix, continue with aspirin indefinitely. As of September of last year, the FDA has given a dual antiplatelet therapy approval for the Watchman in the United States because they changed the device. Now it's called the Watchman Flex. They've had 5 years experience with the device, who gets clots, who got not, and now aspirin and Plavix as an option compared to the transition from blood thinners to aspirin and Plavix. It is basically for stroke prevention in patients who cannot tolerate blood thinners or who have bled. We have many patients who are on blood thinners and they have unsteady gait, they fall, they hit, or who are a profession, their profession by nature put them at risk of increased bleeding, and this is one option we can offer them. And with that, I'm gonna stop. We got 3 minutes for questions. Yes, ma'am. Yes, sir.
Did I understand you to say that the watchman, if you can't tolerate, I think they'll quit twice a day. But if you can't tolerate it, then the watchman is an option.
Let me answer your question. So the guidelines we have in the United States is for Medicare patients, they want to have what we call CHADS VAS score of 3 or higher. 3, you have to have 3 risk factors: diabetes, hypertension, age over 70, or have had a previous stroke. The previous stroke gives you 2 points. Hypertension gives you 1 point. Diabetes gives you 1 point. Age over 70 gives you 1 point. You have to have, for Medicare patients, for private insurance, you have 2 risk factors. I don't know why it is made, but Medicare, I guess, want to push the envelope a little bit more. But these are what we have to go by. Or if you have had a bleeding complication, whether it's blood from any of the body parts. If you have a bled, you are at risk of further bleeding, and we will be considering you for watchman. Without getting into the details, even if you qualify that, then you will be able to get it because there are certain technical criteria about the size of the appendage, or if you have other comorbidities that will disqualify you. But usually we'll bring the patient. I had a patient yesterday, came from Albany actually. He wants us to get the watchman done over here, and I was looking at everything that he have, and I think we're gonna go ahead and get him scheduled, so. Yes, sir.
I'm Jim Shoptaw. I'm a cardiac, thoracic, and vascular surgeon. Basically, we work on the heart and we work on the blood vessels to maintain blood flow to the extremities and to the brain. When I was a little boy, we had a great family physician. His name was Quentin Price, and he was about like an idol for me. I mean, when we were sick, he saw us. We didn't have a whole lot of money. He didn't care. If we were real sick, he told us to go to the back door and come on in and sit in his office till the room got open. And so that probably had a great deal of directing me to want to be a doctor. No, it's a great town. I mean, all the people are nice. I go to a restaurant and sit down. You know, my family's not here yet, so you're by yourself, and you know, people talk to you and smile. And you know, a lot of other places I've been, you just sit there and never hear a word from anybody. But around here, people speak up and ask you where you're from, how you doing, is there anything they could do for you, what, you know, if they can help you figure anything out, and that's really nice to be in a small town. If you can impact a person's time and the quality of life while they're here, then I think that would be a great gift to give a patient.
Very good. So when Dr. Shoptaw came to us back in May of 2021, you know, he and I got to know each other pretty well. I'll tell you, a great guy, and noticed that when he would come in around in the morning, he would sit and look through his notes, and I heard some noise over there. I couldn't tell what it was. And I looked over there, and he had his cell phone out. He had it leaned up against the wall over there by the computer. He was watching his church service there while he was at work. So, you know, sometimes when you're a doctor, you don't get to go to church every Sunday morning. Unless you're Dr. Shoptaw, you get to do it on your phone. So apparently that worked out well for him. I thought very interesting. I saw where I didn't realize. I knew that you'd gone to Medical College of Georgia. I knew you'd spent some time in Mercer. But you also went from Mercer to Baylor. No, from Baylor to Mercer and then back to Baylor again. Is that right? So 2 dips in Baylor. And you went to Presbyterian College for undergraduate training. Now, what is their mascot?
Blue Hose.
The Blue Hose. Huh. Are these like homesick sorority girls or something? I never really understood that one. Nonetheless, we're glad to have Dr. Shoptaw with us at this time. He's going to talk to you about some of the things he can bring to you from a cardiothoracic surgery standpoint. So, Dr. Shoptaw.
I appreciate y'all having me, and I'll tell you a lot of things that people have told me along the way. One of them is if you go by a fence and you see a turtle up on top of the fence, somebody put him there. And I'll say that I'm not standing on a fence post, but I'm somewhat of a turtle in that a lot of people have impacted my life and allowed me to get where I am. You know, first of all, your mother and father. And so I think of all the days that your mother and father whispered in your ear, go this way, go that way. Hold on, don't do that. Maybe try this. And I think what a gift to allow a father, a mother, a grandfather, grandmother to be there just a little longer, to whisper, go right, go left, kind of hold off. Don't get upset about that. And so when I think about cardiac surgery, I think about the fact that if we can impact a few days, you know, I can tell you that a wedding, birth of a baby, they're just all these things that if you just stay a few more days, okay? Now, I think that medicine has gotten away from the fact of responsibility. And I think we as patients need to understand, I'm a bad example of it, obviously, but we need to understand that some of the responsibility of our health is on us. And I'm reminded of the good book. It says in Romans 12:1, to present your bodies as a living sacrifice to God, which is your first act of reasonable service. Don't be conformed with the world, but be transformed by the renewing of your mind. And then you'll know the good and perfect will of God. So, you know, we have to make wise choices, like Dr. Distler says. You know, we have to push away from the table sometimes. I probably should have done that more. We have to get out and exercise. Probably should have done that more. We have to go to the doctor and get him to check us more often than we take our car to get the oil changed. We as women, the women in the group need to say, you know, I'm sorry, Johnny, I'm the wife and you're the husband, but today you're going to have to keep the kids because if I don't take care of my own health, I might not be here, and that'll cost you a lot more than one day. So we need to take responsibility for our own health. I know we at South Georgia Medical Center, we understand who we're working for. I'm reminded of that daily, and Joe Johnson's one of my old partners, and he sent me a text, and he said, if you're diligent in your work, you'll stand before kings. And there's a bunch of translations that says, and if not, you'll stand before either mean men or ordinary men or whatever. I thought, was he trying to say I'm not working hard enough, I'm not diligent enough, and he's the mean man I have to stand before? Or is he saying that, you know, look, you're not working for Ronnie Dean, and you're not working for Dr. Dawson, you're working for the Lord. And so would that change how you approach your daily life? And I think as far as us physicians, we have like a team now. The way it works is like we're working for the hospital, a lot of us are. I mean, there's Dr. State and Dr. Luke, and then this host of other doctors work at the hospital with us. And we look at each patient, so we want to get the right treatment for the right patient at the right time, okay? So Dr. Dawson alluded to the fact they started doing angioplasties. I believe he said in the 90s. I know they started putting in stents around that time, and then there was a great outcry. Let's see what the best is. What's the best treatment? And there were some trials, one of them called the Berry trial. And in the Berry trial, it was a bypass angioplasty revascularization intervention trial. And so it looked at coronary artery bypass grafting versus stent to try to find out, can we just now go away from bypass altogether and just everybody get a stent? And they followed a lot of patients, and they followed them for 5.5 years. And the mortality was like 1.3 for CABG, 1.1 for PCI. Myocardial infarctions were greater in the open heart surgery because you stopped the heart. And then there was a higher risk of stroke in the bypass surgery, like 0.8 to 0.2%. But then when they looked at survival, their survival was a little bit better for the bypass patients, like 89% versus 86. But then they looked at the diabetics, and the survival for the diabetics at 5.5 years was 80%. It was only 63 for the PCI group. There was another study, the EAST trial, which compared PTCA and coronary artery bypass grafting, and it was 3 years. And by the time they let all the patients get out of the study that they could remove, they had about 392 patients. And they found out there that the way I kind of, in my mind, I make it simple, that like if you look at the front of the heart, there's one artery, it has branches. The back of the heart, one artery, it has branches. And the right side of the heart, and it has branches. So let's just talk about one vessel, two vessel, or three vessel blockage, okay? Front, back, and right, okay? So basically what they said is if you have just one vessel blocked, generally speaking, medicine's probably all right and probably just as well as anything. And then if you have two vessel blockages, probably you do better with a stent, and you might even do better than a heart surgery or than having medicine along them. And if you had three vessels, you kind of did better with having a surgery, especially if your heart was weak and especially if you had diabetes. Okay, so they kind of had thousands and thousands and thousands of patients, and that was with bare metal stents. So then they started putting drugs on the stents, and Eddie can go into the intricacies of different drugs and what they use and all that. But the point is they had a new therapy, a better stent. And so now they're saying, one of my friends had a slide, and the heart surgeon was up there talking, and his slide had this drug-coated stent, and it's just running down through the thing, and it's almost like it knocked the speaker off the platform. Like, you know, you won't even be here in 5 years, because now that we got the drugs on the stents, no more heart surgery. So they did the Syntax trial, which they just came out with a 10-year data for the Syntax trial. And what they found, again, if you have severe three-vessel disease with a high Syntax score, and you have a weak heart or you have diabetes, that you do benefit from heart surgery. Now, there is an upfront risk of a stroke, like it's going to be a little higher, say 0.8 to 0.3. And the kind of confounding factor in that study was we always used to think if the first part of the main artery on the left side had blockage, left main stenosis, that you would do better with heart surgery as opposed to stent. But we didn't find that in the study. We found that the left main patients did equivalent. But that the patients that had three vessel disease with severe blockages, they did do better if they had heart surgery, if they had severe three vessel disease, and they had depressed left ventricular ejection fraction, especially if they had diabetes. So what are you telling us? I'm telling you, I'm a heart surgeon, and I still got a job because we still do heart surgery. And the takeaway point is that if you have a low ejection fraction and all the arteries are blocked and you're a diabetic, heart surgery needs to be on the table as a potential option. Now, once we look at the patient that can have heart surgery, not all the patients are fit enough for heart surgery. So what we do in our contemporary practice is Dr. Distler says, hey, I think this guy needs heart surgery. And so we ask the patient, are you active or not? And if the patient just lays in the bed and they don't get up, more than likely they're not fit for heart surgery. So they have to have a performance status that's good. We check their lungs. A lot of times people have really bad COPD and their lungs are too poor to get on the ventilator, get on the bypass machine, and get back off. So they kind of exempt out from that. Some people have kidney failure, and some people have liver failure and problems with their blood clotting. But we look at each of those patients. We also look at their neck arteries, and Dr. Hardy may talk about that, cerebrovascular disease, and how we already know that we're at a high risk or higher risk doing a bypass surgery of having a stroke, and we don't want to have everybody have a stroke. So we look at their neck arteries. If they have something that we can improve by doing a revascularization to their neck artery at the same time of the heart surgery, it might be doable. Otherwise, it's not an option. So we constantly discuss with the cardiologist, and then he said, okay, I want you to do the heart surgery. And we go, well, they got this. We think a stent may be better. Now, we know they probably won't live as long if they have a stent as they would if they were a candidate for heart surgery, but if we're going to have a problem of not getting out of the hospital, being stuck on the ventilator or whatever, what kind of life is that? So we would stop. And just to show, once we look at the data, we find out what the right treatment for the right patient at the right time is, then we have to go back and look at what we did, and we have to say, did we do a good job or not, okay? And so in the last 57 patients that they did the data on at our hospital, the results were amazingly well. Like the mortality at 30 days was 1.8%, and the STS database, which is thousands and thousands and thousands of patients, was 2%. We used the mammary artery, which is shown at the Cleveland Clinic 25 years ago, that it's like a 90% patency at 10 years, and almost every one of those patients had a mammary if they could use the mammary. The deep sternal wound infection rate was 0, and across the nation it was 0.2. People staying on the ventilator here, about 7% stayed on the ventilator after 12 hours as opposed to 9% with the national database. And we had 0 renal failure requiring dialysis, and our readmission rate was acceptable at 7% as opposed to 9% in the national database. So what I'm telling you is we look at the national standards and we try to decide what's best for this patient going along with the national standards. But then we just don't throw it to the wind and say we did right, so whatever happens, happens. No, we go back and look how the patient did. And then we try to say is, did we help Grandma Sue or did we help Uncle Larry, stick around longer? Because, we're family. I mean, we don't want Uncle Larry to do bad. I mean, it hurts our feelings. If we lose a patient, it's like losing a family member. And so I'm gonna just share you one vignette of a scenario that I think may be avoided if I kind of jump up and down and turn on my head and tell you the story. There was a lady that was about 62, and she was fit. I mean, that lady was fit. She went out and walked around Stone Mountain 3 times a week. I mean, she was fit. She did Pilates, she did yoga, she did all that stuff. She had 2 dogs, and she walked them around the neighborhood when she wasn't at Stone Mountain. And she had a lot going on, a lot of kids and a lot of stuff and a lot of work, and it got to where she didn't walk as much, but she was still fit. I mean, she looked really good. Every now and then she'd get on the Atkins and jump about 20 pounds down, and then she'd kind of drift up and dump it back down. Really didn't go to the doctor ever, didn't really have good insurance, and really didn't care about going to the doctor. And why'd she need to go? She was fine, perfectly fine. So one day the lady called me and said, "Hey man, I'm feeling terrible. Not only am I feeling terrible, I think I'm gonna die." I said, "Whoa, that's bad. You need to go to the doctor." So where do you go when you're feeling terrible, you're about to die, it's the middle of the day? You go to the urgent care, right? So she goes to the urgent care, and the guy puts the blood pressure cuff on. He says, "Taking your blood pressure medicine?" She said, "Medicine? I don't go to the doctor. I'm fit. I walk around Stone Mountain 3 times a week. I exercise. If I get a little overweight, I take an Atkins and drop it on down." He says, "Blood pressure 230 over 130. Kind of high. You probably need to come in the hospital." "Oh, I got a lot to do, man. I got 2 meetings this week. I'm on the board of this and that. I got to go to these meetings. I don't have time for that. Get my blood pressure down and we'll worry about it." "Okay, we'll do that." So then they say, "Well, it's still like 200 over 130, and we just don't think we're happy at the urgent care. Maybe you can go to the emergency room." So she goes to the emergency room. Now, you're talking about an economic genius here. They don't have enough money to go to the regular doctor, and now they've gone to urgent care, and now they're going to the ER. So let's just think about how much that's costing. But, trying to get the person to live is a big deal too. So they go to the ER, the blood pressure, they get it down to like 165 over 100, and then they get the patient to just swear that they're going to go see their doctor the next day. "I'm going to go see the doctor the next day." So they get to feeling better the next day. They gave them some blood pressure medicine. Their blood pressure's better. And so they say, "Well, I probably ought to call my brother. He's a doctor, and see what he would say." And I say, "Man, you need to go to the doctor. I mean, you're sick, So about a week later, get a doctor's appointment. 2 weeks after that, get a cardiology appointment. 2 weeks after that, get a stress test. And then 2 weeks after that, get a cath. I mean, we're looking 2 or 3 months down the line. That's how it happens, right? You're feeling better, and so they put you off and put you off and put you off. So you get a heart cath, and then they say, "Well, you got 99% blockage in your right artery, 99% blockage in your front artery, 99% in your back artery. You really need to have heart surgery, but you need to call somebody and see if they can do your heart surgery, because we don't know what your insurance is and all that." And so they call around and they find, "Well, this guy over here can do it, but says he's got so much work, it's going to be a week. So if you want to stay at the hospital a week and just sit there and pay for all those days, you can do it, or just go home." "Fine, you say I can go home, I'll go home." So they go home and they sit there for a week, and they come into the hospital, a big, famous, successful hospital, the next week. And because their brother's a doctor, his buddy is getting them right in. And they take them to surgery. And I don't know what, you can say there's a term that says something hits the fan. I don't know what it is, but something hits the fan in there. And I mean, things just fall apart. I mean, it's like, normally the operation takes 3 or 4 hours. I mean, it's like 6 or 7 hours, 8 hours, you know, don't hear anything. And so then they call us and they say, another classic case of the doctor's family member and how things just went to crap, okay? And so that's my sister, right? And so the nurse in the unit at the hospital says, she matriculates well and she does well. And the nurse looks at her and says, you know, when they call me from the operating room, I can't believe you made it up here alive. I mean, you know, like everything just happened. I mean, bad. And what I'm trying to tell you is you don't have to let things get that bad out of shape. Because if you know, an ounce of prevention is worth a pound of cure. That was my sister. She's a doctor's sister. And she just never went to the doctor. And then the doctor looks at me in the waiting room and he says, is this your sister? I mean, genetically, are you related to this person? And I said, yeah. He said, man, you need to get checked. He said, that lady's just, I mean, she's about dead and she about died and she's terrible. And, you know, I don't know if she's going to live another 5 years and you need to get checked. And I bet if we took a vote in here tonight and took a register, that you guys' cars, the oil gets changed more often than you check on your heart. And you probably take your grandchildren and take care of them for your children to go to the doctor more often than you go yourself. And so, as the kind of the final point, I'm going to share something big with you, and I know this is hard to believe, but there's a verse, it's called Job 14:5. It says, seeing his days are determined, the number of his months is with thee, and thou hast appointed bounds that he cannot pass. Guess what? Everybody in here is going to die. And all I'm telling you is, all of us have limited time. Let's use our time wisely, and let's take the body that God gave us and take care of it. Because God wants us to have faith, and he wants to look after our families, and he wants to serve. And in what place do you think Valdosta would be without the good God-fearing people in this room, in the cemetery, and no one to whisper to those in front of them? Because you remember in the Bible it says it took one generation to forget God. You guys have been through the fire. You know things don't always go the same. You've seen the stock market crash a few times, and guess what? It came back, and you can whisper to that kid, it's going to be all right. You know, Psalms 37:25, it says, I've been young and now I'm old. I've never seen a righteous man forsaken nor his seed begging bread. That might be just the word that your kids need to hear. But if you're pushing up daisies somewhere in a cemetery because you didn't decide to present your body to God and you didn't come and let these people try to figure out how to take care of you best they can, you're not going to be much help. And God, I believe America needs the older voice and the wise voice to keep us out of the ditch. All I'm saying is do the best with what you got. God's going to take you home when he can. But if you can stay here as long as you can, your kids and this town will be better off. Have a good evening.
Well said. I think you certainly understand my point that I was making about Dr. Shoptaw earlier. I mean, I don't think there's no question that I think that one thing that I really like about working with this group that we have, not just the cardiologist, and there's some of them that aren't here tonight because, you know, somebody's got to take care of the patients today, right? Some are on call, some are still working. But you know what? Is there any question about how much he cares about his patients? Is there any question when you hear any of these people, I can tell you they care about their patients. And very transparent about everything. I mean, hey, listen, I'm no stranger to the smoking pig, okay? I've been there before. It's all right. You know, we had one of these patients, he went to go see one of our new cardiologists, didn't know him that well. And one of these cardiologists says, look, I can do all these procedures, but you're gonna have to clean up your act. You gotta knock it off. You gotta start eating like you need to. You need to quit smoking, doing all that kind of stuff. But you know, he saw another guy in town, another doctor in town, who was his long-term primary care family doctor he'd known for a long time. And he went to him, he said, "Doc, I talked to this new cardiologist, and he told me, he said, if I stop drinking, if I stop smoking, if I start eating what I'm supposed to, and I exercise every day, am I going to live longer?" He said, "Well, it's sure going to feel like it." That's okay, though. I think, it doesn't take one bad trip. It doesn't take one piece of lemon cake to get you in trouble, okay? Right? It's a recurrent thing. But we do have a problem in this region in general. In 2006, at one point, Brooks County, Georgia had the highest number of diabetics per capita than any county in the United States. Any county in the United States. So that's a true story. The next person I want to introduce to you is a close personal friend of mine, Dr. David Hardy, and I see that his bride's now here with him as well. Nice to see you. Dr. Hardy I know very well because Dr. Hardy, he went to medical school at the Medical College of Georgia from 2003 to 2007. That class was full of superstars, I'm going to tell you. We were in the same med school class together. But David Hardy is one of the best people you'll see. He went through med school at MCG in Augusta. He did his general surgery residency there at Medical College of Georgia. And one thing that happens when you go through training is they'll kind of help you to have an incentive to come back there when you finish your training. He went off to do his fellowship at Cleveland Clinic. I think I'm getting this all right. If I'm not, you have to correct me afterwards. But he went to Cleveland Clinic to do his training in vascular surgery, not just vascular surgery, but he does endovascular surgery where he uses catheters to do things. He came back to Medical College of Georgia because they brought him back there. He was there for a few years. And then they wanted him back up at Cleveland Clinic where he worked as an attending physician up there, right? But other than all the good food we got, there's some other good things about the South too. And warm weather is number one on the list, right? And I've been to Cleveland before. My eyes burnt for the whole 5 days I was there. Every time I walked outside, I was glad to get back home and get back down to South Georgia again. But Dr. Hardy is very conscientious. In fact, when I was pulling in this evening, I looked up my rearview mirror and I saw David coming in behind me. Now, you might find this hard to believe, but I can be a little bit mischievous at times. But I saw Dr. Hardy as he's pulling in, so I go ahead and I pulled up there and I got in the parking space up there. And as I got out and I'm getting ready to come in, I looked down and I saw that I parked in a reserved spot. And I looked around for David. Now, David parked all the way in the back there by himself, so he wasn't getting anybody's way. That's David Hardy. He's that kind of guy, very conscientious. Whenever we talk about patients, he is extremely thorough to make sure he does the right thing. Very well respected in that regard. And I want to go ahead and see if we can play his intro if we can now, please.
I'm David Hardy. I'm a vascular surgeon. I'm originally from Georgia and moved to Ohio for about 3 years, and now I am just starting at South Georgia Medical Center here in January. When I tell my friends and family or just someone in the grocery store I'm a vascular surgeon, they say, "Oh, you do veins, right?" And then they proceed to show me their vein on their calf. And that's true. We do work on veins, but we work on every blood vessel in the body. I guess the simple way is to say I work on every blood vessel, artery and vein in the body except the heart and the brain, basically. Coming to the hospital, it was actually really nice. So I'm coming down from Ohio, which the weather there is not the best if you grew up in Georgia like I did. You get used to wherever you're at. But coming here to the hospital is really great. The people are phenomenal. That's kind of, if you can find a place where you can work and the people are great to work with, I mean, you've won the battle, or you've at least won half the battle. When I was 16, I became a janitor at a doctor's office. Honestly, I had no real direction, if that's the way to say it, other than I did okay in school. I was a good kid, and the doctor at that doctor's office, he's a family medicine physician, called me in and said, "You know what, you need to do something with your life, and you'd be a great physician just the way you act and treat people." In my senior year in high school, I took a health occupations class, loved nursing, and that was it for me. So I started college in a nursing path, took a couple of anatomy physiology classes, and loved school so much that I said I want to do something where I'm in school or learning the rest of my life, kind of thing. And that really is what kind of clicked me back to that first moment in a doctor's office when I was a janitor, and said, this is what I'm going to do. I can do it. I proved to myself I can do it, and yeah, here I am. One time we were doing a case on a lady who could not walk, like she couldn't get her mail, she couldn't get out of the house, and it was because she had no blood flow to her legs. And we went in and put some wires and stents and just some stuff. It was almost like magic at that time. And she, like an hour later, she felt the difference in her legs. And then seeing her come back in clinic, I had the fortune, she said, you know what, I can get out to the store, I can go to Walmart, I can get to the post office. And I thought, that's it, that's what I want to do, because it was such an extreme turnaround on how she did. My philosophy is that I'm going to do the best I can. That's the philosophy I tell my kids with anything they do, and if you can do the best you can do and look yourself in the mirror, that's all you can do. There's nothing anyone else can ask of you. So when I'm with you, you're my patient. There's nothing else that matters. And sometimes that causes you to run a little late because you really just want to be with that patient and take care of all their problems. But yeah, when I'm with you, you're all that matters. I treat you like family. I treat you like I'd want my mom, my wife, my dad, my kids to be treated. And I mean, I think that's just that's just life. And that's the golden rule.
I can tell you that it's almost kind of inspiring for me to even see that. You know, I tell you, David Hardy, he's the kind of guy, I tell people that he's one of those kind of folks. This isn't my best analogy, I'll give you this, okay? But he's kind of like Billy Graham. If you say something bad about him, it doesn't make Billy Graham look bad. It makes you look bad, you know? David, please come on up here.
All right, thank you. Thanks, Dr. Dawson. Thanks, South Georgia Medical Center. This program has already peaked because you've had a bunch of amazing physicians and surgeons that have spoken to you. I was sitting over there watching all this talent give us a talk, and I work with them every day, so I'm like, I know who they are. But it is pretty amazing to see what they do and to see that we all work together, to know that we all communicate very well with each other. And like I think Dr. Shoptaw said it, we all just kind of work together as a unit. And we're all employed by the hospital, so we all feel like some sort of ownership for this community, for this hospital, and all we want to do is to make it better. We want to make your lives better. We want to improve the care of our patients here in Valdosta, and I think we're doing a pretty good job. So the disclosures I have, I don't really have any disclosures, but there will be pictures. So I'm sorry, they're not going to be great. But what is a vascular surgeon? Like I said in the intro, when I say I'm a vascular surgeon, people say, oh, you do veins, right? Yes, that's exactly what I do. But it's not just veins. It's not the varicose vein in the leg. It is every blood vessel in your body, except for the heart and the brain. The heart and the brain, those are for the cardiologist here, Dr. Shoptaw. That's what they do very well. We do far more than surgery. So I'm here, and my title is vascular surgeon for that standpoint. But like everyone has repeated, we treat lifestyle modification. We want you to make lifestyle changes. That 30 minutes a day of walking, 5 days a week, is really the minimum. And it doesn't have to be joining a gym and perspiring and being out of shape and your knees are killing you. It really is just a walk 5 days a week if we could do that. After we work on lifestyle changes and medication regimens, I can go and sit and read ultrasound. So it allows me to kind of read and do a little bit extra. So we're doing that in the day too. But I feel like what I do most of the time is I spend about 80% of my time when I see patients. I know surgery's in the title, but I think I feel like I try and talk about 80% of my patients out of surgery. There is no reason a lot of these patients need surgery if we can work on lifestyle modification. And if we can't stop smoking, a lot of times we do these treatments and they don't really last if we can't start with lifestyle and start with you. again, we are able to do, so as a vascular surgeon, since it's kind of showcasing what do we do, so we're able to do every kind of, or supposed to be able to do every kind of vascular procedure in the body except the heart and the brain. And we do it with minimally invasive techniques called endovascular. We're doing it with open techniques. And most of the time nowadays, we're doing it with a hybrid. We're in these rooms doing open and endovascular at the same time. So there's this old saying, when you're a hammer, everything's a nail. I don't like to think of us or our specialty that way, because we can offer the breadth and the depth of open and endo and maybe try and choose the right thing for you as a patient. So this last statement, we're treatment agnostic, I would say. Like today, I did a carotid stent. Could we do a stent and only a stent? No, we could do it open, we could do the stenting, and that's where you know the data, you present these options, and you let the patient just kind of, you give them the data, and you work together as a team to figure out what's best for your patient. Relationship building. One of the things I really liked about vascular, when I went through medical school, I thought I wanted to be a cardiologist. I thought it was really cool what they do. I still think it's cool, but I realized they were way smarter than me, so I just became a plumber instead. I also wanted to be a neurologist, but again, too smart for me. And I think, but the thing that really got me in surgery, and vascular surgery particularly, was I really liked medicine. I really liked taking care of patients. I really liked that relationship building. And with vascular surgery, when I see you as a patient, we're probably going to know each other for the rest of your life, unless I do something to make you angry and you don't show back up. Because vascular disease is a long-term disease. It's not, I put hernia, and I'm not picking on a surgeon who does hernias. They are needed too, but if you have a hernia surgery and it goes well, you don't ever have to follow up with that. It's done, it's taken care of, looks great. But if you come in and I'm fixing your carotid or your aorta or something, those things are chronic diseases that we will follow the rest of your life. So I really like that relationship part of my job. So yeah, I just said that. So how do you see a vascular surgeon? How do you know when you need to come see me? Fortunately, what I've noticed, we have a lot of primary care physicians in town and a lot of really good ones. And they are usually referred to you by your primary care. So like Dr. Shoptaw just gave you this great talk about taking care of yourself, about going to see your primary physician. That's how you know to come see me. When your primary physician says, this is what you have, or I'm concerned about your blood pressure, or whatever, then they can send you to me, or Dr. Hanna, Dr. Shoptaw, Dr. Distler, or any of the other cardiologists we have on staff, because they're very good at getting you in, and I've had a really good experience. I think the team here is pretty phenomenal. Sometimes we see inpatients, and this is one of those unfortunate things. If you're in the emergency room for belly pain, and maybe it's unrelated, but you get the CAT scan, they'll find an aneurysm, they'll find something else that we have to look into. So if you end up getting the CAT scan, you will find a lot of things that maybe you didn't know you had. But the whole point is getting to somewhere for someone to look at you. So some of the things we look at, pain in the legs. If people are walking, or if you go out for a walk and you're having cramping in your legs, if you used to be able to walk a mile, now you can walk 100 yards, and it's getting shorter and shorter with the pain. That could be peripheral arterial disease. If you have PAD, you have CAD, coronary artery disease. So that's why all these blood vessels kind of go hand in hand. We do deal with venous disease, veins in your legs, varicose veins, clots, DVTs, pulmonary emboli, clotting disorders. We see patients that are smokers, diabetics, high blood pressure. So it is a full service when you're seeing a vascular surgeon, not just the surgery part. This is kind of where the pictures go. What do vascular surgeons do? Again, this is a picture on the left of maybe a typical angiogram or an interventional procedure. We stand on one side of the patient. There's a little device in the background that is giving off radiation. Unfortunately, I get radiated all the time, and I get these reports every month or every quarter saying that I'm above the radiation dose. But that's kind of the price you pay to take care of people. We are able to move wires, treat diseases, push wires, put stents in, and balloons. This is an open surgery. I had made it bigger on one of my PowerPoints, but this is, maybe you can see it. This is an open surgery. It's pretty gross, I guess, but to the screen right, the patient's head is there. There is a lung, at the head, so there's a lung kind of over in here. This white device is a piece of Dacron fabric. This is what we put in people when their aortas rupture or burst. And if we're fortunate enough to get you to the operating room in time, we can clamp it and actually hopefully save your life. If your aneurysms rupture, it's typically about a 90% chance that you won't make it. You won't survive that. So there's only about a 10% survival in those procedures. This happened to be a patient I took care of years ago that ruptured, and I know the people that know, like Shoptaw or whatever, I put that device into a large portion of an aorta. But this person was not doing great, and I was the only person there, and this was the best I could do. Got the bleeding to stop, and then stented. So if Shoptaw's asking the question, that's into an aneurysmal portion of that, then I ended up putting a thoracic endograft up and sealing it off. So it all kind of worked out, and we got the patient sealed, and they walked out of the hospital about 8 days later. So that's kind of one of my, and then that was no small feat, because I had to, those small little devices or branches that are coming up at like a 90-degree angle, those are all feeding the patient's kidneys and gut blood vessels, the stomach, the liver, and all that. So those were all individually sewn in as well. So that was kind of a tough night. And then we sit down. This is probably the real reason I did vascular surgery, because I get to sit down most of the day and do my surgeries. So again, this has come up over and over, but medical management, I mean, these are things. I love bacon. I could do a better job. Fortunately, I was 300 pounds at one point, and I'm not 300 pounds anymore, so I do make lifestyle changes. And then luckily, my wife is pushing me to eat better, so that's probably the best I can do. But I agree, we all have to manage our blood pressure, watch what we eat. And the smoking, if I could get people to stop smoking, we definitely could cut less legs off in South Georgia. Non-invasive labs. So when you're coming to see us, a lot of people have a lot of ideas that we're going to cause pain, and it's going to be difficult, and it's scary. Well, a lot of times we start off with just non-invasive laboratories, and these are a couple of pictures of people having an ultrasound done. In vascular, we have great ultrasonographers. I will put that out there for our team. I think we're the only ones who just do vascular only, and they don't do anything else other than blood vessels. We're in the certification to be accredited at a national level right now. So I'm pretty proud of them. They can look at almost any blood vessel in your body with an ultrasound, so that you don't have to have radiation or CT scans and things like that. So our hospital and the professional building, second floor, we offer all these services, and it's been pretty easy to work through. This is that hybrid room. I had a good picture of this, so I wanted to show it. It's pretty amazing. You might think this is like a Walmart or Target on a Friday night. It's so empty and huge, but this is an operating room. The machine is over in the corner. The bed's in the middle of the table or in the room. We can do open surgery and cut you anywhere in your body to get, like if you get a gunshot wound, if your aorta ruptures, if we need to fix your carotid, if we need to put a dialysis access, this room is for that. If we need to use radiation to put wires, balloon stents, it's pretty amazing. So it is a great resource we have at South Georgia Medical Center. I didn't have any pictures of our full team, but I would say one of our staff members came tonight. Laura is kind of new in the last few months sitting over here. She has been an excellent addition to our team, and she has, we actually did crazy cases today. We did some complicated carotid disease. We went right after that and did an aortic aneurysm repair. And then after that, I exposed a spine. So that's kind of what we love about our life. It's always something different day in and day out. These are examples, if you kind of know, all right, well, what does that machine show you? It gives you little pictures like this. And when I squirt the contrast, some people call it dye, when we squirt it in, anywhere you see black is where blood is flowing. Anywhere you see a void of black, so like this picture right here does not have any blood flow, and I guess on this left one right here, there's no blood flow in that blood vessel, and that's the stuff that I do with a wire to put stents. That's the stuff Dr. Distler, Dr. Hanna, we're using these wires to get in, and anywhere you can put a wire, you can put a stent or a balloon. I did put this because I wanted to show, if you know anyone who's had an IVC filter, I had this cool video I wanted to show you. That is an IVC filter in someone's vena cava at the bottom. And I know you think we're all gentle and all this stuff and it's so tedious. You will see in a second me bend this catheter like a bow, like I'm trying to shoot a bow to get this filter out. That's how stuck these are. But that's also why we try to talk you out of surgery when you don't need it, because there's a lot of damage that could happen trying to get this out. And you'll see it pop out in just a second. And don't worry, this patient did fine. I've never had anyone bleed, but you can see how not delicate that is to pull a filter out of a vena cava. So an example of an aneurysm that is here, it's on that bottom left or top left screen. You can see the big bulge in the aorta. After placing a stent, this is still amazing to me that the technology is there. If you look at this small, the bottom left picture, that is, I don't have a reference, but that's about as wide as a pinky finger maybe. And that's all we do to fix an aneurysm nowadays. We can fix it from the inside of the blood vessel. We got cool tools. That's also kind of a draw. There's a laser machine right here. We can go into blood vessels and laser them open. We can burn holes in things like fabrics to create holes for stents. These metals, when we say stents, some people don't know what that is, but it's back. It's that middle device, these scaffolds. There are balloons here. The balloons don't go in and stay in. They just blow up like any balloon. They suck down, and then we pull the balloon out of your body. And then we do open surgery. This is a whole host of different things that we might see in a week. In that top left picture, that's someone who had a ruptured aneurysm. We had to cut open through their side to go in and get into their chest to fix it. The middle top picture is an amputation. Someone has diabetes or a dead leg or whatnot. That bottom left picture is someone who actually almost got run over by a forklift years ago, or I think it was some sort of sharp instrument went through, and you can see the artery, vein, and nerve in that picture. So, it's never a dull moment with what we get to do. And then lastly, I would say public service announcement. I can't tell you how many of these I fixed when someone gets unruly, drunk, not making sense, punches through a glass wall, and that's what happens here. But fortunately, this little tiger striped looking device is the vein out of that person's leg, and we were able to save that hand. So I think it just makes you feel good that you can provide a service to make people's lives different. This is vein surgery. This is what most people think I do. When you have the bulging varicose veins, we have lasers, we have super glue to put in veins. We can pull the veins out by an operation and hopefully get your veins back to bikini weather in no time. And then finally, kind of out of time, but like, what's the best thing? We have a full breadth of patients and that we get to see a large variety of procedures. It's never boring. Emerging technology. I'd say the biggest thing, I talk about the people in the team, but the team we get to work with, like working with our office staff back here, excellent. It's been, anytime we need something done, everyone's so helpful moving forward. A nurse practitioner I get to work for, I think 2 of them are back there, is BJ, and then Dr. Coleman is the main person I work with, and if they're not there, I can't do what I do. In fact, I don't think I'd want to do what I do without their help, because they make all the difference. So I appreciate y'all letting me speak, and thank you so much.
All right, outstanding. So what we're going to do is right before we close out, I'm going to go ahead and see if we can have all 4 of our docs to come up, and we're going to do about 10 minutes of QA. Are we okay with that, Kara Hope? All right, she's the boss. Well, everybody's gathering up here. I want to take an opportunity. Come on back up, David. I want to take an opportunity just to thank everybody for being here. In particular, I want to point out Miss Garland, Ms. Shirley Garland, who's here with us, and her husband, James. She's one of our board members that they have the responsibility for oversight of the hospital. And it's one of the things that attracted me to this organization is that you have community members that are on a board that communicate and come in, and we meet frequently. Some places they meet like once every 6 months or even once a year in some places. But here, this is an active board. They are involved. Ms. Garland is a healthcare provider herself. She's a nurse. She's a nursing supervisor. She was a boss lady when I came around back in the day. She retired a few years ago, but now she's come back and she's serving in another role. So we're very thankful for her and all the other members of our board. I want to make sure I point out too, Kara Hope. She's here with us today. She's from our Department of Marketing, and they do community relations. Dana Massagill's here with us. I hate to start naming people because I'm inevitably not going to name the right person, and I'm going to have to blame one of them for me forgetting to name somebody, but it takes a lot of people to be able to pull these kind of things together, and we're very thankful for all the guidance they give us. We are doctors after all. We're not really able to put together anything that's actually, I mean, we can do some stuff, but not, not the basic stuff that normal people can do, it seems like. So let's just take a few minutes here and we'll see if we can do a little Q&A, and then we'll finish this up at about 7:20, and we'll do some closing remarks, and we'll let you guys get home so they can get back and operate in the morning. As you can see, they probably need to be able to concentrate. Okay? All right. Questions?
I was just wondering if any of you, because I had mitral valve repair about 12 years ago, so I know eventually it's going to have to be replaced. Is that something that we're moving toward in the future, or is that something that we're still, because I know that Dr. Saint had to come from Gainesville at the time, and I just wondered if that's something that we're taking care of here now.
We are, Dr. Brown does the structural heart disease at the hospital. He's the surgeon that's kind of over that. And he does mitral repairs, and he does mitral replacements, and he does aortic valves and ascending aortic arch aneurysms and dissections. And he and Dr. Seabolt together are running the TAVR clinic. And the TAVR, if you don't know what that is, it's you go in through the groin. It's a percutaneous aortic valve replacement, and there's a procedure that they can also do to the mitral valve called a mitral clip, and kind of that's the next horizon of the structural heart. But we do open valve surgeries now, and there are some percutaneous mitral valve options that are down the line. But we're in our infancy. I think in the TAVR program they've done 22 cases. They've had 0 mortality. And they had a breakfast the other day, and the patients ranged from, I think, in their 70s to like 93. And they were very happy with the care they got. And they do those 2 or 3 a week. And so as we grow that work, we'll kind of start doing the mitral clips and other things. There's also, I know Dr. Hanna talked about the atrial fib ablations and how he did a seamless job on the cases he presented, but on some cases on the back wall of the left atrium, you can't get some of those areas, and there's a procedure called the convergent procedure where you can go in with a little subxiphoid incision and ablate the back wall of the left atrium. We're just about to do the first case of that. Dr. Brown did those up in Macon, and we'll be starting to do those here as well. So there's a lot of new things that we're doing, but we like to do one thing at a time and kind of, show that we can be successful and take good care of the patients before we jump on something else.
In women, we hide our pain, or we don't recognize the pain of heart disease. Is there an age that if you're not really having extra symptoms or overwhelming symptoms, that you should have some type of test, whether it be a stress test or whatever? Is there an age that you should have something done as a baseline, or is that something you just wait for whenever you have symptoms?
That's a good question. I'll answer that one. I think that's my wheelhouse. No, we've looked into that. We wondered for women, for men, is there a certain age where we should do standardized stress testing for everybody? And the answer is no. But the key is to have that good relationship with your primary care, to notice if there's anything different, any symptoms that are different, out of ordinary. Or we do know that some risk factors, you're diabetic, blood pressure, cholesterol, if you're a smoker, that will cause us to maybe push that forward for that stress testing. So no, it's not one size fits all. We put the whole picture together. It's not indicated to do a stress test on every single person because it'll lead to stream procedures sometimes that may not be indicated. So we try to put it all together, but it depends on your other risk factors, really. Mm-hmm.
I was born with a heart murmur in '69, but I did not have to have surgery because it came through. And I was adopted, and I do not know my medical history. Should I ever be concerned that anything would come of that? Nothing's ever happened to me, and I'm 53 years old, but I'm also dealing with unknown medical history.
So a murmur is a sound that we hear of your blood going through your heart. So you'll hear, and often kids will get diagnosed with a heart murmur. It's a doctor or nurse hearing a sound of the flow of blood going through your heart. Sometimes that can mean that there is a valvular issue, like a mitral, aortic, tricuspid valve. Sometimes it's nothing, and it's simply the flow of blood through the heart. So it's hard to say what that was and what that is for you. Seeing a cardiologist could help figure that out. We would look with the ultrasound or an echocardiogram to see what, and we would hear with our own ears, our experienced ears, to say, hey, that is due to just simply the flow through the heart, or it's due to a pathology or something wrong with the valve itself. So it depends on what it sounds like and what we see on the ultrasound.
If I'm asymptomatic, should I see or have a cardiologist?
I would have your primary care listen to you and say, hey, listen to my heart. What do you think? What do you think about that noise? And then if they believe that it's something that needs to get looked at farther, then yes, see a cardiologist.
Thank you. And I've got one more question. I've never asked the doctor this before.
Uh-oh.
Who has...
Not only one lemon cookie, not two.
I'm just curious. What has been the youngest and the oldest age of a patient you have, the four of you have worked on, that has stuck out in your mind the most?
I got a good one. So this was in training a couple years ago. I had a 103-year-old patient who was planned for a TAVR. He could walk. He could do it. He could do his own thing. He was scheduled for 7:30. He showed up at 9:30. He was dressed with a suit, with a top hat, and he said, and the doctor who took care of him, he's a world-renowned in the area of structural cardiology, trained a bunch of fellows, and he walks right up to the doctor, and the doctor says, "You're late." He says, "When you're my age, it starts when you show up." And he was right. He knew it. He walked right in there, looking like a 10 out of 10, and he said, "It starts when I show up." That's my story.
Yeah, I think he beats me by a couple of years, but yeah, I tell a lot of people this story, but a 101-year-old gentleman who had an aortic aneurysm that we repaired with the small incisions. I do not recommend this at all, and I tell my patients don't do it, but I fixed him on a Friday and he cut 5 acres. It was a riding lawnmower or a tractor, but he cut 5 acres that Sunday. So wow. People are just built differently, I guess, is what I would say. And I think all of us in training probably took care of babies and newborns and prematures, but yeah, I think I would. There's so many of those. It's hard to talk about.
Yeah.
I think with the kids, with the babies when they're born, they had a congenital heart surgery service at the Texas Children's Hospital, and there were some babies where your arteries take off your coronary arteries take off of the wrong artery, like they come off of the pulmonary artery. They're supposed to come off the aorta. So early in their life, in the first few days, you have to go in there and switch those arteries over. Or a little kid that's born with some congenital anomaly where you have to do a heart transplant at a very, very early age. And, I think by the grace of God, some of those kids actually have productive lives. And I can tell you that at Texas Children's, they don't give up on a single kid. They give it for everything.
I think we have time for one more question.
Okay, I just wanted to say thank you to South Georgia. We moved here from Memphis, and one thing I noticed when I came with some health issues. that a lot of people had this notion that they had the expert from afar, that if you had to have something done, you needed to travel outside of Valdosta. And for working reasons and lots of things, that wasn't always the thing to do. And I found after multiple times visiting South Georgia for surgeries and things that I had great care. And so I just want to thank you all for having this kind of thing that lets the community know that you don't have to travel. Like, I'm thrilled, Dr. Hanna, that you're here, because I go to Mayo and I love my Dr. Kuzimoto, but you're right here, and that gives me comfort. So I want to thank you for that. And I do have one quick question. I'm just curious how much you all look at family history. Like, for instance, I'll be 72 soon, an older brother with major AFib, a mother, a brother in his 60s who died of sudden cardiac arrest. I have some heart issues caught with mitral and stuff. I'm not going into my personal stuff. But how much do you all find family history plays in patients that you end up seeing?
It's a big component. What I always say with my patients is we are what God gave us, we are our genes, and then we are what we did with those genes. So it's a big part, but for me, it's what did you mix into that pot? So the genes are important, and we are what genes we are made of, but what did you do with that? Did you smoke for 50 years? Did you, so it's an important part, but it's what you did with it and what you're feeling now. So it's not just family history. Family history is important. We can only, we'll hear stories of patients that they'll say, yeah, well, my neighbor says that she smoked until she was 99. Well, she had good genes. You didn't. You don't. You got to put the cigarettes down, right? And so yes, genes are there, and they are important. Family history is important, but it's what you did with it too.
I'm going to add one word to your question about AFib. It plays a tremendous amount. Genetics plays a big role with AFib. Statistically, if one parent has AFib, the children has a 50-50 chance. If both parents have AFib, you are guaranteed that sometime in your life you're going to have AFib. And to go back to what Dr. Distler said, I always believe as I grow in my career after 23 years of practice, the creation was perfect. The Lord wrote the genetic code perfect. It's what we do on this life that changes everything. To echo what my colleague said, everything we do from cigarette smoking to not taking care of our bodies, it eventually will pay a price for that. Dr. Kuzimoto is my trainer. He's my mentor. He's trained me on doing these cryoablations at the Mayo Clinic. Great guy. Very, very good guy.
He's a good guy. Thank you very much for everybody coming tonight. And I think that one thing, if I want to emphasize a couple of the major themes that were touched on tonight, is if you have anybody that, if you have any kind of symptoms that come on suddenly, if some part of your body stops working all of a sudden, then you need to call 911. You need to get to the hospital. And one reason I encourage people to call 911, we know in this county that the average response time is about 8 minutes and 48 seconds. Now granted, depending on where you live, it might be a little longer, it might be a little shorter. But they have the advantage of that radio, and they can get certain things in motion as you're on route coming in. They can do an EKG in the field, they can send it forward, they can notify Dr. Distler and his colleagues so they can start to get things together. That's the real secret to being able to get these fast door-to-balloon times.
It's pretty cool, actually. We get a picture of it on our phone, so I know what I'm telling my team, what catheter to pull, what wire to pull before you even show up. It's on the table, it's ready to go.
So there you go. So that's the advantage that we have with this seamless health system. And I will say that one thing that I was very attracted to when I came here is having left Mayo, where we just had a hospital and a clinic. We didn't have a rehab unit. We didn't have one. We didn't have the EMS service. We didn't have one. But you could imagine, like for a guy who's a stroke specialist, and here I am in the buckle of the stroke belt. I mean, look, I take care of sick people, okay? I mean, that's what I look for. And then you got this facility that has everything from soup to nuts, where they have the EMS service all the way through the ICU, the ER, everything in the hospital, and then the inpatient rehab. I mean, they had everything across the board. And I talked to the guy that was recruiting me up here at the time. He said, look, we want somebody who can give thrombolytic therapy in our ER. I thought, well, what do you know? I'm just the guy for the job. And that's what we look for with this. And I've made a very big point. We were interviewed on the mayor's radio show, I don't know, probably about 8 weeks ago, I guess. And as these guys were talking, I always smile because I took a big part in recruiting every one of the guys up here. And I can tell you, I'm real picky about who I recruit as a chief medical officer. Because if they act up, I have to deal with it, and I don't want to put up with that. No, it's mostly because I'm lazy, okay? But I want to tell you all that I'm very thankful for everything you've done and coming here tonight, and everything that you bring to our community. And I want you to be able to push this back out to your friends and family, people you see at work, church, any kind of community events that you're with. If you have any kind of acute symptoms that happen suddenly, please activate the EMS service via 911. And if you don't have a primary care physician, you need to find one. And I say physician, sometimes it's a nurse practitioner or some PA, but you need to get in with somebody a couple of times a year, let them check your blood pressure, let them do some basic lab work if they think that's indicated, and they can answer a lot of these questions for you, okay? And it's good to have somebody that knows you. I mean, I'm very impressed with some of these primary care docs we know in town, where they just look at somebody years and years and years. They go in there and pay the money and see them, and then after about 13 years, he says, you know what, something just doesn't look right. There's something to that, okay? There's something to that. Guys, thank y'all very much.